Good morning teachers, seniors and batchmates. Today I am presenting interesting case number 652/22. History of the patient is 55-year-old lady presented with multiple erosions all over body since 10 days. Patient was apparently alright 10 days back, then she started noticing scaling and redness over back and upper chest, which gradually progressed to whole body. History of fever and chills since 4 to 5 days. Past history of similar episode 3 months back which subsided with medication. Patient gave history of taking analgesic 3 months back, following which she developed rashes or erosions. There was positive history of photosensitivity but no history of itching, psoriatic lesions or pedal edema, joints pain or loss of weight or appetite. Personal history, she was a non-vegetarian, bowel and bladder movements were regular. Family history, nothing significant. Menstrual history, she had attained menopause 10 years back. Systemic examination, respiratory system, central nervous system, cardiovascular system and per abdomen examination were all within normal limits. Coming to local examination, there was diffuse ill-defined erythematous to hyperpigmented erosions and plaques associated with scaling seen all over the body. Oral mucosa showed solitary ulcer present over left buccal mucosa. Genital mucosa was not involved. Pavitron sign was positive. Nikolsky sign was negative. Bilateral inguinal non-tender lymphadenopathy was noted. An obstetric examination showed vaginal prolapse. These are clinical pictures of the patient where we can see left side mucosa showing the solitary lesion, and these are skin lesions on the face and neck, and these are the lesions over the scalp. These are the lesions over her chest and neck region. These are the lesions over trunk and lower limbs. Laboratory investigations, hemoglobin was 9.4 gram per deciliter, WBC count was 6000 per cubic millimeter, platelets were 3.4 lakhs per cubic millimeter, differential count was neutrophil 79, lymphocytes 16, monocytes 2, eosinophil 3 and basophils nil. Absolute eosinophil count was 180 cells per cubic millimeter. ESR was 34. Peripheral smear showed normocytic normochromic anemia with relative neutrophilia. Liver function test and renal function test were within normal limits. Other investigations done were ultrasound abdomen and pelvis, which was not significant except some fatty changes in the liver. Chest X-ray, right lower zone patchy pneumonitis with right pleural effusion or pleural thickening was noted. Clinical diagnosis made or working diagnosis was drug-induced erythroderma, Pemphigus foliaceus or subcutaneous lupus erythematosus. Zang smear was done from one of the bulla lesion over the lower limb. Here we can see scattered some squamous cells and nucleate squams in the low power. Here in the high power we can see several nucleate squams and some squamous cells with some few inflammatory cells. Zang smear reported was smear studied shows squamous epithelial cells and anucleated squams with inflammatory cells composed of neutrophils. Advice given was punch biopsy for confirmation of diagnosis. Punch biopsy was sent with the differential diagnosis of erythroderma, Pemphigus vulgaris, Pemphigus foliaceus and DRESS syndrome, that is drug reaction with eosinophilic systemic symptoms. This is a photomicrograph of punch biopsy under low power where we can see is intraepidermal blistering, that is suprabasal blistering is roughly seen in many of the places, and there is denusion of the epidermis. This is closer view or the 20x view of the same pic where we can see denuded epidermis and there is more clearly visible suprabasal clefting here, here and all this. This is another side of the view where we can see acantholysis in the lower epidermis and intraepidermal clefting. And this is the high power view of the pic to show suprabasal clefting and acantholysis in the lower epidermis with acantholytic cells. So microscopy given was epidermis line based stratified squamous epithelium, mild spongiosis and intraepidermal acantholytic blister with suprabasal clefting. Dermis showing inflammation around adnexal structures and fibrocollagenous tissue. Impression was Pemphigus vulgaris. Coming to review of literature, the word pemphigus is derived from Greek word pempix, meaning blister or bubble. Until the early 20th century, all blistering diseases were grouped under this name. In 1953, Liver distinguished Pemphigus vulgaris and Bullous pemphigoid on the basis of clinical and histopathological features and their natural course. Pemphigus vulgaris are group of chronic autoimmune bullous dermatosis that are characterized histologically by intraepidermal blister formation and immunopathologically by the presence of bound and circulating autoantibodies directed against the intercellular adhesion structures of the epithelial cells. Epidemiology. The incidence of Pemphigus vulgaris worldwide varies between 0.09% to 2%, that is 1 to 10 cases per 1 billion people across the world. Pemphigus is more common in Jews and in people of Mediterranean descent and from Middle East. In India, Pemphigus occurs in younger age group, that is less than 45 years, as compared to Western country. Male to female ratio is almost equal, with few studies showing female predominance. Pemphigus is an autoimmune blistering disease presenting clinically with flaccid intraepithelial blisters, erosions and ulcerations of the skin and mucous membrane. Histologically with acantholysis and immunologically with in vivo bound and circulating autoantibodies against the cell membrane components of keratinocytes important in cell-to-cell adhesion. Circulating autoantibodies are present in about 80% of patients with active disease and their titer usually correlates with disease severity. These antibodies are demonstrable by direct immunofluorescence testing of skin and indirect immunofluorescence testing of serum. Antibodies detected are predominantly immunoglobulin G type. Pathophysiology of Pemphigus. The target antigens of Pemphigus are located in the desmosomes. The most prominent adhesion junctions are in the stratified squamous epithelium. The desmosome complex contains desmoglenins and desmocholine as transmembrane constituents, and placoglobulin, placophilin, and desmoplakin as cytoplasmic constituents. This is a schematic diagram to show intercellular desmosomes. These are desmoglenin, these are desmocholine, and this is placoglobulin, and this is placoplaquilin, and this is desmoplakin. Desmosomes exist in 4 isoforms, namely desmoglenin 1, 2, 3, and 4. Desmoglein 1 is expressed in greater intensity in the upper layers of the epidermis but in only small quantities in squamous mucosa. Desmoglein 3 localizes primarily in the deeper layer of epidermis and throughout the thickness of squamous mucosae. Mucosal epithelium expresses mainly desmoglein 3 but skin expresses both desmoglein 1 and 3. Damage by antibodies to desmoglein 3 results in oral lesions with or without skin lesions. If both desmoglein 3 and desmoglein 1 antibodies are present, cutaneous lesions as well as mucosal lesions appear and the disease tends to be more severe. Pemphigus disorders can be broadly divided into 5 types. 1. Pemphigus vulgaris with its reactive state, that is Pemphigus vegetans. Pemphigus foliaceus with its lupus-like variant and endemic variant, Pemphigus erythematosus, and its endemic variant Fogo-salvagum. Drug-induced pemphigus, immunoglobulin pemphigus, and paraneoplastic pemphigus. Pemphigus vulgaris. This condition develops primarily in older individuals presenting with large and flaccid bulli. They break easily and leave denuded areas that tend to increase in size by progressive peripheral detachment of the epidermis, leading in some cases to widespread cutaneous involvement. Skin lesions can be observed in any location, but there is a prediction for oral mucosa, trunk, groin, armpits, scalp, and face. The palms and soles are usually spared. These erosions become covered by crusts with no tendency to heal. Healing is usually without a scar, but pigmentary changes may be observed. These are photomicrographs to show oral lesions. Here we can see a vesicle blister and excretion on the lips and in the buccal mucosa and palate. Here serohematic acceleration and crusts on the lips are seen. These are cutaneous lesions initially how Pemphigus vulgaris presents with. These are vesicles, tense, and they are clear. Later they become turbid and flaccid as shown here, which later rupture, the blisters rupture leaving painful areas, oozing and denuded skin. that continues to extend slowly with little tendency to heal. And these are some more photomicrographs to show the Pemphigus vulgaris lesion. These are vesical blisters with excoloration on the dorsum. Here accelerations and crusts on the back. Here accelerations and crusts on the scalp and behind the ear. Histopathology of Pemphigus vulgaris. The earliest changes are intercellular edema and disappearance of intercellular bridges in the lowermost epidermis. Loss of adhesion between epidermal cells, that is acantholysis, leads to the formation of clefts and then bullae in the suprabasal zone. The basal cells remain attached to dermis, producing a tombstone appearance. Here we can see there is intercellular edema with eosinophilic spongiosis and loss of intercellular bridges in the lowermost epidermis. Here this part. Here we can see eosinophils. An intraepidermal acantholytic blister has a suprabasal cleavage plane. Acantholysis may extend into adnexal structures and stratum. Here it can expand down. This is a photomicrograph to show basal layer of cells remain attached to the dermis. More clearly seen in this photomicrograph, giving a row of tombstone appearance. This is a direct immunofluorescence photomicrograph where we can see there is lace-like squamous intercellular space deposition of immunoglobulin G in the lower epidermis. This is the lower part of the epidermis and upper part is here. In the lower part we can see there is immunoglobulin G deposition in the intercellular spaces. Pemphigus vegetans. Pemphigus vegetans is a localized form of Pemphigus vulgaris in which there is a localized vegetating papillomatous response. The eroded areas do not heal like usual but form papillomatous growth and vegetation. This is an uncommon variant of Pemphigus vulgaris, comprising only 1% to 2% of the cases. Historically, Pemphigus vegetans has been divided into the more severe form called Newman type and milder form Helopio In the more severe Newman type, the disease begins and ends as Pemphigus vulgaris, but many of the denuded areas heal with verrucous vegetations that may contain small pustules in the early stages. These are the photomicrographs to show Pemphigus vegetans, showing marked hyperplastic erosive plaques looking like papillomatosis. Histopathology of Pemphigus vegetans. Suprabasal cleft similar to that in Pemphigus vulgaris is seen. Here there is papillomatosis and acanthosis with occasional formation of intraepidermal eosinophilic abscesses. The papillary and reticular dermal infiltrate is composed predominantly of eosinophils. Here you can see intraepidermal abscesses are composed of eosinophils and few acantholytic keratinocytes. Here there is marked acanthosis, you can see acanthosis here, and suprabasal cleft containing eosinophils. Pemphigus foliaceus. Pemphigus foliaceus is characterized by small flaccid bullae with crusting and scaling. The initial lesions are scaly papules or superficial flaccid bullae or erythematous skin. The bullae readily rupture, resulting in moist erosions and cornflake-like crusts. Lesions are usually sharply demarcated as opposed to the extending erosions of Pemphigus vulgaris. The seborrheic areas like face, scalp and upper trunk are initially involved, but later the disease may become generalized and can present as erythroderma. Coming to histopathology of Pemphigus foliaceus, the cleft is in the granular layer or right beneath it may develop into a bulla with acantholysis. Dyskeratotic changes in the cell of granular layer are diagnostic and is frequently observed feature in all lesions. Here we can see in the subcorneal blister. There is a subcorneal blister here with neutrophils in the cavity of that blister. In the setting of subcorneal blister, these dyskeratotic acantholytic granular cells are diagnostic of Pemphigus foliaceus. Immunofluorescence of Pemphigus foliaceus. Intercellular immunoglobulin is deposited in intercellular presses throughout the epidermis. As seen here, it is throughout the epidermis it is deposited. Rarely, as in this case, the immunoglobulin G is present in greater quantity in the superficial layer. Here, the superficial layer shows more dense deposition of immunoglobulin G. Coming to Pemphigus erythematosus, also known as Senar-Usher syndrome. Pemphigus erythematosus, a localized variant of Pemphigus foliaceus, is characterized by appearance of erythematous scaly plaques, thin-walled bullae and denuded areas, predominantly seen on the butterfly area of face, upper part of back, chest and intertriginous area. Patients of immunopathological features of both Pemphigus and lupus erythematosus. Exacerbation on exposure to sunlight are common. The disease resembles Pemphigus foliaceus in its lack of oral involvement. Histology of Pemphigus erythematosus. The histological appearance are identical to those of Pemphigus foliaceus. In this biopsy, the roof of the vesicle is eroded. Here the roof is already eroded, leaving a diminished but acantholytic granular layer. Endemic Pemphigus foliaceus. This is a distinctive form of Pemphigus that is clinically, histologically and immunopathologically identical to Pemphigus foliaceus. Lesions are seen on sun-exposed areas of skin. It occurs endemically in densely forested areas of South America, disappears when jungle is cleared. It is also called by name Fogo selvagum. Pemphigus herpetiformis. Pemphigus herpetiformis combines the clinical features of dermatitis herpetiformis with immunologic and histologic features of Pemphigus, usually the foliaceous type. This variant deserves recognition only because of its clinical presentation. Patients present with pruritic erythematous vesicular or papular lesions, often in herpetiform pattern. Mucous membranes are uncommonly involved. Histopathology of Pemphigus herpetiformis. There is eosinophilic spongiosis with or without acantholysis. Variable numbers of neutrophils may be present, leading to neutrophilic spongiosis or subcorneal pustules with both eosinophils and neutrophils. Coming to immunoglobulin A pemphigus. Immunoglobulin A pemphigus is a pruritic pustular eruption characterized by squamous intercellular immunoglobulin A deposits and intraepidermal neutrophils. There are two subtypes. One is intraepidermal neutrophilic immunoglobulin A dermatosis and subcorneal pustular dermatosis type. Both the subtypes have similar clinical features. Flaccid bullae or pustules are seen on normal or erythematous skin. The pustules tend to coalesce in an annular or circinate pattern with central crusting. Coming to histopathology of immunoglobulin A pemphigus, in the subcorneal pustular dermatosis type, an intraepidermal pustule with numerous neutrophils is seen subcorneally here. In the subcorneally. In the intraepidermal neutrophilic type, the neutrophils are in the suprabasal and stratum spongiosum. And here. Coming to paraneoplastic pemphigus, is an autoimmune vesiculobullous and erosive mucocutaneous disease associated with an underlying malignancy. There is presence of unique antibodies directed at desmosomal plaquins. Neoplasms associated with paraneoplastic pemphigus are lymphoproliferative and hematological disorders like non-Hodgkin's lymphoma, chronic lymphocytic leukemia, Castleman tumor, Waldenstrom's macroglobulinemia, and thymomas. Both humoral and cellular autoimmunity responses are involved in the pathogenesis. The antibodies involved are predominantly of immunoglobulin G1 subclass and directed at multiple autoantigen including members of Plankin family of cytoplasmic proteins as well as desmoglein 1 and 3. Commonest lesions seen are painful erosions and ulcerations of the oropharynx and vermilion border of the lips as seen in this photomicrograph. This appears to be a lymphoma in the neck. Histopathology of paraneoplastic pemphigus. Erythema multiforme like pattern. There is a cell-poor interface dermatitis with apoptosis of keratinocytes. There are also Pemphigus vulgaris like changes with suprabasal clefting. Here we can see poor cell interface dermatitis type with inflammatory cells and there is suprabasal clefting. Lichen planus like pattern. There is a cell-rich lichenoid dermatitis associated with suprabasal blister. As we can see, lichen planus like pattern of interface dermatitis with suprabasal blister. There are both intercellular and basement membrane staining with immunoglobulin G by direct immunofluorescence. Here we can see there is intercellular deposition of immunoglobulin as well as on the basement membrane. Coming to neonatal pemphigus. Neonatal pemphigus occurs in 30 to 45% of children of Pemphigus vulgaris carriers by the passage of maternal antibodies to the fetus through the placenta. It is manifested by vesicles, blisters and erosions from the moment of birth, and the involvement of mucous membrane is rare. Neonatal pemphigus is self-limited and the condition regresses within 3 to 4 weeks of birth as maternal antibodies are catabolized or eliminated. Coming to drug-induced pemphigus. Drug-induced pemphigus is caused by two types of drug. One is thiol drugs which contain sulfhydryl or thiol group in their chemical structure. Example, penicillamine, captopril, paritinol, pericoxicum and thiopronine. Others is non-thiol drugs like penicillin, ampicillin, amoxicillin, cefadroxil, rifampicin, propranolol, phenytoin and phenobarbital. The drugs appear to stimulate the disease in those with the predisposition to develop pemphigus. Histopathology of drug-induced pemphigus. The findings in the early eruption are non-specific, consisting of spongiosis, parakeratosis and a variable dermal infiltrate. Well-developed lesions are essentially identical to those of Pemphigus foliaceus or Pemphigus vulgaris. Eosinophilic spongiosis may be prominent. Immunofluorescence CNR study of serum reveals circulating squamous intercellular substances immunoglobulin G antibodies in 70% of cases. The antibody titers are usually low and do not appear to correlate with the severity of disease. This is a table to show different types of antigens targeted by immunoglobulin G in Pemphigus disorders, like in mucosa type of Pemphigus vulgaris where only mucosa is involved. The antibodies are directed against desmoglein 3. In mucocutaneous type, they are directed against desmoglein 3 and desmoglein 1. In Pemphigus foliaceus type, it is directed against desmoglein 1. In paraneoplastic Pemphigus, they are directed against desmoglein 1, desmoglein 3, desmoplakin 1, envelopacin, periplakin and plectin. In drug-induced Pemphigus, which is autoimmune variant, the antibodies are directed against desmoglein 3 and desmoglein 1. In toxic variant, no antibodies are seen. In immunoglobulin A Pemphigus type, the antibodies are directed against desmoglin 1, desmoglein 1 and desmoglein 3. Coming to differential diagnosis of Pemphigus vulgaris, one is Hailey-Hailey disease and transient acantholytic dermatosis. In Hailey-Hailey disease has full thickness acantholysis giving a diapediated brick wall, epidermal hyperplasia and an impetiginized scale crust. The acantholysis does not extend down follicles as it does in Pemphigus. Transient acantholytic dermatosis may exhibit small foci of intraepidermal acantholysis, but these are only a few retivide in contrast to the uniform widespread acantholysis observed in biopsies of Pemphigus vulgaris. And immunofluorescence is negative in Hailey-Hailey disease. This is a photomicrograph to show Hailey-Hailey disease where we can see entire thickness acantholysis. Despite of acantholysis, the keratinocytes are still holding to each other by thin intercellular bridges loosely to each other, giving a dilapidated brick wall appearance. And there is suprabasal clefting and lacunae. Another differential layer, Darier's disease, is characterized by focal acantholytic dyskeratosis and readily separated from Pemphigus vulgaris by the presence of abnormal granular keratinocytes and parakeratotic cells, so-called Kopp's rounds and Kopp's grains. Here we can see dyskeratotic granular cells. Suprabasal clefting and lacunae is there, and the acantholytic cells or granular cells become dyskeratotic, leading to formation of Kopp's rounds and Kopp's grains. Kopp's rounds have round nucleus with perinuclear halo and eosinophilic cytoplasm called Kopp's rounds, whereas Kopp's grains are elongated cells with elongated nuclei and eosinophilic cytoplasm. Although light microscopic examination of Pemphigus lesions is important, positive direct immunofluorescence is the gold standard in diagnosis at the time and must be persuaded in all cases in which Pemphigus vulgaris is considered. These are my references. Thank you.